Good afternoon, everyone. My name is Greg Marchildon, and I'm the Site Director for the Western Regional Training Center in Health Services Research, and this is our twice-a-month seminar, and it's my great pleasure to be able to introduce our guest today, Dr. Brian Hutchison, and I just would like to make a few comments about Dr. Hutchison's background, so that provides a bit of a personal context for what he's going to present today, which has really been a lifetime of work, I would say. Dr. Hutchison started professional life actually as a family physician. He was in a fee-for-service group practice for about 5 years, followed by 25 years in academic family practice at McMaster University. From 1994 to 1999, he held a National Health Research Scholar Award from Health Canada. And significantly, because some of you have had exposure to the Center for Health Economics and Policy Analysis, CHEPA, from McMaster University, you will understand how important that institute has been in terms of understanding both health economics and disseminating the methods of health economics in the country and policy analysis, but also its direct relationship with policy decision makers. Although that's been concentrated in Ontario, I would argue has had a knock-on effect in the rest of the country. And Dr. Hutchison was the director of CHEPA from 2002 to 2005. He's also the founding editor of Healthcare Policy, now the predominant peer-reviewed journal in the field in the country. He did this from 2004 to 2009. In 2004, he was the recipient of the Health Services Research Advancement Award from the Canadian Health Services Research Foundation. And in 2008, received the Lifetime Achievement Award in Family Medical Research from the College of Family Physicians in Canada. And recently, and in fact very recently, just in the last 2 years, was the president of the Canadian Association of Health Services and Policy Research. And in fact was a board member in the Justice Emmett Hall Memorial Foundation for his sins of being the president of CASPR. And I know this because I'm the president of the Emmett Hall Foundation, and for my sins I have to be on the board of CASPR. These are very incestuous organizations that work very closely together. But he will be talking to us about something that he's been conducting research on and trying to, in a sense, evaluate for decades now, and that's primary health care research. And it's in the context of Canada as a whole, not just Ontario, but Canada as a whole. And I would argue puts it into very much an international context, because Dr. Hutchison has spent a fair amount of time trying to understand primary health care models in other jurisdictions. So we're delighted to have you here today, Brian, and I'd like everyone to join me in welcoming you here.
Well, it's a pleasure to be here, and I'd like to thank Greg for the invitation and the hospitality he's shown over the last 2 days. I never imagined I'd meet as many people as I have in such a short period of time, but I think Greg figured if he was going to pay my way out here, he ought to get his money's worth. So I'm going to talk about the evolution of primary health care in Canada. Actually, I noticed Greg had the abstract I sent. It had a better title than this, or at least a little catchier title. I think I had it something like Coming Out of the Shadows, the transformation of primary health care in Canada. I wanted to learn to work the machine. There we go. So I wanted to just remind ourselves that healthcare and primary health care more specifically is a public good. And so I've got here a quotation from Norman Bethune from a speech that he gave to the Montreal Medical Surgical Society in 1936 when he says, "The protection of the people's health should be recognized by the government as its primary obligation and duty to its citizens. Health protection becomes public property like the post office, the army, the navy, the judiciary, and the school, is supported by public funds, and is available to all not according to income but according to need." What's a bit remarkable about this is that it was delivered about 30 years before these principles were applied to the provision of physician services in Canada. But it's also, I think, a reminder that the road from good ideas to their application is often very long and tortuous. And I think that's certainly been true in primary health care. We've often known what to do, the kinds of things that would strengthen primary health care in this country, but it sometimes seems awfully hard to make it happen. So I'll do some definitions here. This is a fairly standard one from Barbara Starfield. And she defines primary care as that level of the health service system that provides entry into the system for all new needs and problems, provides person-focused, not disease-oriented care over time, provides care for all but very uncommon or unusual conditions, and coordinates and integrates care provided elsewhere by others. Primary health care. Hi, Jack. Primary care is at the core of primary health care, but extends beyond primary care to include health promotion, community participation, and intersectoral action to address the determinants of health. Give a moment for Jack to get settled there. Thank you for coming. I thought I would spend a little time kind of skipping over some pieces of evidence just to highlight the importance of primary health care to overall health system performance. And this first quote is from Barbara Starfield, who was reviewing the evidence from international comparisons related to primary care. And she says, national healthcare systems with strong primary care infrastructures have healthier populations, fewer health-related disparities. And this is an interesting one. There's been a fair bit of research that not only shows overall better health outcomes, but fewer health disparities among countries with very strong primary healthcare systems, and lower overall costs of healthcare. She, along with her colleagues, reported in 2003 on a study where they looked at 18 wealthy OECD countries and found that the strength of the country's primary care system was negatively associated with all-cause mortality, all-cause premature mortality, and cause-specific mortality from pulmonary and cardiovascular diseases. Baker and Chandra reported a study in 2004 in Health Affairs where they used data from 50 US states, and they found that the more specialists there were, the higher the costs and the lower the quality. More primary care physicians, lower costs, higher quality. There's also been similar results from studies both in Canada and the UK. So Gulliford looked at 99 English health regions and found that a lower GP supply was associated with increased hospital utilization for both acute and chronic conditions. And more recently, Emmanuel Perard from the University of Waterloo did a study that examined changes over time in population health across Canadian provinces and found that a higher supply of specialists correlated with worse health outcomes, and a higher supply of family physicians was associated with better health outcomes. She used waves of the National Population Health Survey in doing this work, and is now kind of incorporating an additional wave to see if this relationship continues to hold over time. So I could have spent a whole talk just kind of looking at what we know about the contribution that primary health care makes to overall health system performance. But I thought I'd just highlight some of that evidence before getting into the main part of my talk. So I'm going to talk about where we've been in terms of primary health care, particularly looking at the pre-2000 period. Then I'm going to go on to look at the period after 2000, from about 2000 on to the present, about how the system, primary health care system has changed, or primary health care systems, plural really, each province and territory being unique. How the primary health care systems have changed during the first decade and a bit of the century. Then go on to look at where we're at right now nationally in terms of primary health care performance, and finish by talking about what remains to be done and how we might get to where we should be heading. So looking at that pre-2000 period, in the 1960s, we saw the introduction of universal public insurance for physician services, but with a continuation of fee-for-service remuneration, physician clinical autonomy, and control over the location and organization of medical practice. And that was really kind of what's sometimes referred to as the founding bargain for Medicare. The profession came in on those terms, and they've kind of dominated much of what's happened or what's been possible since then. In the 1970s, there were some innovations in alternative organizations and funding models, including the CLSCs in Quebec and the development of community health centers in Ontario and other similar innovations in other provinces. However, they tended to be relatively small in scale. CLSCs less so, but never becoming a dominant model in Quebec. During the mid-80s through the 90s, there was a broadening of the range of primary care providers, variable across the country. The main professionals that started to be trained in significant numbers were midwives and nurse practitioners during that period. And then in the mid-1990s, we saw a plethora of primary care reform pilot and demonstration projects. Julia Abelson, John Lavis, and I wrote a paper that was published in 2000, really kind of looking at the developments up to that time. And we called the paper, or the subtitle for the paper, "So Much Innovation, So Little Change." Primary care reform in Canada during the 80s and 90s was really characterized by false starts, timid initiatives, myriad small-scale pilot and demonstration projects. There were a lot of kind of futile calls for sweeping big bang reforms under very unfavorable circumstances, and which, in our view, really meant that it was part of why so little happened, that the scope of what was being advocated was so far out of keeping with what was possible given the policy legacies and other constraints that policymakers faced. On the other hand, there was an unwillingness to kind of embrace the concept of incremental change. Hence, we had this period of stasis, really, in terms of primary care reform. Unlike many other countries, we're moving ahead during this period with major innovations in the way primary health care was being organized, funded, and delivered. During this period in Canada, the innovations that were happening, and there were a lot of them, were really at the periphery of the system rather than at its core. And from my perspective, as a clinician and health services researcher, it sort of felt like this. I don't know whether you can read the caption here, but it says, okay, everyone just calm down and we'll try this thing one more time. 10 years later, things are different. We're not there yet, but there's been a lot of activity around primary health care development during the post-2000 period. I'll talk a little bit about that now. So two major reviews of the Canadian healthcare system were conducted at the beginning of the 2000s. Both were completed in 2002 and made recommendations to government that helped to chart the course of primary health care reform. The first, I don't know which is the first and which is the second. I think the Kirby came out a little bit before, but the Standing Committee on Social Affairs, Science and Technology, often referred to as the Kirby Committee, issued its report in 2002, and they proposed that the federal government provide ongoing financial support for reform initiatives that lead to the creation of multidisciplinary primary health care groups. They went on to recommend that these groups provide access to a broad range of services, 24 hours a day, 7 days a week, utilize nurse practitioners to the fullest, integrate electronic health records, and be funded through capitation or blended funding formulas. So they were fairly concrete in what they were proposing, and it's kind of interesting to think about how much of that has happened in our province or since that time. The Romanow Commission, the Commission on the Future of Healthcare in Canada, which Greg was very much involved in, also addressed the issue of primary health care. They said that 4 essential building blocks should define primary health care across the country: continuity of care, early detection and action, better information on needs and outcomes, and new and stronger incentives for healthcare providers to participate in primary healthcare approaches. So their recommendations were they made some specific recommendations, but their general recommendations were at a fairly high level. Since 2000, the federal and provincial territorial governments have made a series of policy and funding commitments to support the reform of primary health care in Canada. So the first 5 bullets here are the objectives agreed to at the first ministers' meeting in 2000, at which time the federal government established the $800 million Primary Healthcare Transition Fund to accelerate primary healthcare reform. And those 5 objectives were to increase access to primary healthcare organizations providing a defined set of services to a defined population, increase the emphasis on health promotion, disease and injury prevention, and chronic disease management, expand 24/7 access to essential services, and establish interdisciplinary primary healthcare teams. This was 2000 when these goals were articulated, linked to the Primary Healthcare Transition Fund. You can look at it as a glass half empty or glass half full when you think about where we're at now in relation to those objectives. The 2003 First Minister's Accord included a $16 billion federal government investment in a health reform fund targeted to primary health care, home care, and catastrophic drug coverage. Very few, if any, strings attached. A lot of sense that that money went somewhere, but it's not clear how much it did strengthen primary health care, home care, or catastrophic drug coverage. And then at their meeting on the future of health care in 2004, the First Ministers established a goal of 50% of Canadians having access to multidisciplinary primary health care teams, 24 hours a day, 7 days a week by 2011. Arguably, Alberta is the only province that's approached that figure through their primary care networks. And the nature and strength of those primary health care teams in Alberta is quite variable. Other provinces have moved in that direction, some pretty timidly and some more aggressively. They also, at that meeting, made a commitment to accelerate the development and implementation of the electronic health record and telehealth initiatives targeting remote and rural communities. The general approach during the post-2000 period to primary healthcare reform in Canada has had 4 main features. First is voluntary participation of both providers and patients, incremental approach to system change, a pluralism of physician payment and organization models, and engagement of provincial medical associations in policy development and implementation, in some provinces to a greater extent than others. And I would argue, in fact, that the provinces where the change has been greatest, whether you like the change that was made or not, were in those provinces that really took engagement with the Physicians Association seriously. They may have had to compromise some of their objectives, but they were able to make changes. So the next couple of slides just kind of summarize what I see as being the key initiatives that have been undertaken across the country with respect to primary care transformation. And the picture is quite variable across the country. No province has done all of these things, and some have done very few, others have taken on a substantial chunk of this. But these include the expansion of health professional training programs, especially for physicians, family physicians and nurse practitioners. And there's been a huge increase in medical school enrollments and the development of nurse practitioner training programs. Should I just keep going, Greg?
Keep going.
Okay. There's been a development in terms of group practices and practice networks. Again, it's varied from province to province what form that's taken and the extent to which it's been done. This sometimes has been linked to the development of interprofessional primary healthcare teams, sometimes not necessarily linked to networks. In terms of team-based care development, that's been particularly noticeable in Ontario, Quebec, and Alberta, less so in other provinces. Although, again, I think that every province has made some efforts around the development of interprofessional teams. In Ontario now, roughly 20% of family physicians are working in comprehensive primary health care teams. In Quebec, there's a similar proportion, maybe a little more, working in their family health groups. And in British Columbia, I think they're up to about 2/3 of the population are served by primary care networks, which have an interdisciplinary component. Quality improvement, training, and support are sort of on the agenda almost everywhere. I think the work has been most advanced in BC, Saskatchewan, and Alberta. Ontario has come on more recently and is now working very actively to support and train primary care providers in quality improvement principles and methods. There's been a move towards financial incentives to target particular health system goals and in general toward blended physician payment schemes that incorporate various combinations of fee-for-service, salary, capitation, sessional payments, and fees that target particular activities or performance targets. In a number of areas, there's been development of contracts and accountability agreements, and certainly I know in Saskatchewan there are a fair number of primary care physicians working on contractual arrangements with the ministry. And that's true in many other places. There's been a move that's been limited to Quebec and Ontario to have patients enroll with a primary care provider. So in Ontario now, 75% of the population is enrolled with a primary care provider. In Quebec, it's around 25 or 30% now enrolled with a family health group. I mean, the case for this is really around identifying a practice denominator, a population to be served, kind of changing the orientation from reacting to people coming into the practice to having responsibility for a population and orienting, thinking towards what does that population need and how can we as a practice meet those needs and how can we proactively reach out to them. Enrollment also has the tremendous advantage of allowing performance measurement. You know what you've got as a denominator. measure your performance and track it over time. And do comparisons across practices, across geographic areas, and potentially. So you can see I'm an advocate for the patient enrollment approach. And it's controversial. 2 provinces have picked it up and the rest have shunned it. Sometimes doing workarounds using patterns of seat of care to identify a virtual practice. Is it okay to take a question? Sure. I'll repeat it.
Actually, you know, it may be better to do it after something because
Okay. So you'll be first on our list for questions. There's been significant investment in information management at the practice level, the introduction of electronic medical records. Again, as you'd expect in Canada, big variability across the province. Wealthy Alberta is ahead of everybody else in EMR implementation and, for that matter, in interconnectivity. Other provinces not doing so well. But increasing everywhere. Use of EMRs, not just for billing purposes and so on, but for clinical record. There's also been e-health investments in terms of developing interconnectivity and also in the development of telemedicine approaches. And finally, still limited and inconsistent, but increasing investment in evaluation of innovations. Certainly in Ontario, that's picked up a lot over the last decade. The sad thing is that the results of the evaluations are often not made public. Kind of private property of the ministry that many of us are struggled with and struggled against that. But so far, no big breakthroughs. I'm going to move on now to talk about kind of the current state of things. We continue to be in a situation where in primary care, as in medical practice generally, we have public payment for private practice. So physicians are for the most part, independent contractors. And there are obvious implications to that continuing to be the dominant arrangement. You can negotiate with physicians that they're not employed by ministries of health and aren't subject to the kind of direction that they might be under other arrangements. Family physicians, and this is a long-standing situation in Canada, comprise 50% of the physician workforce. They continue to work predominantly in solo and small group practices, much fewer solo practices than even a few years ago, all on the decline for 2 decades. A tendency for group practices to be larger in size, but still most of them are probably 5 or less. So they're small units, so hundreds or thousands of practices in all of our provinces. About 90% of Canadians have a regular doctor, according to most recent Commonwealth survey data. And some variation across the country, but not a lot, except for Quebec, which has historically had a much higher proportion of their population unattached. And in general, when public is asked to comment upon the care they receive from their regular care provider, they value it and regard it highly, in spite of lots of specific complaints about some of the shortcomings of primary health care. So in the next few slides, I'm going to look at primary health care performance in comparison to other countries at a similar level of economic development. I'm drawing on these from the Commonwealth Fund's 2008 and 2009 health policy, international health policy surveys. The 2008 survey was a general population survey. The 2008 survey was a survey of sicker adults. The 2009 was a survey of primary care physicians. We now have more recent survey data, but I haven't incorporated it into these figures. But the picture has not, there have been some changes, but the overall picture has not changed significantly since the earlier data. So I've stuck with my earlier slides on this. I'm focusing on the bad news, not the good news, so that there are areas in which our performance is middling or better that are measured in some of the OECD work and in the international health policy surveys. I'm really focusing on where the opportunities are for improvement. So I'm presenting an unbalanced picture. So I've done these as radar graphs, and I don't know how well they're showing up on the screen, but in each of these, the brown line represents the highest performing country among those surveyed. So in this case, it's 8 countries, which are Australia, Canada, France, Germany, the Netherlands, New Zealand, the UK, and the US. And so the outer brown line is the best performer among those 8 countries, and the inner sort of purple line is Canadian. And as you look at the concentric rings there, they each represent 20% of respondents. So on this one is various measures of access. And the gap between Canada and the best performing country is greatest for timely access to care when sick, access to after-hours care, and avoidance of ER visits. We have a much higher rate of ER visits per capita than most other developed countries. And we have a higher proportion of people who when asked, say that they would have not needed to go to the ER if their regular provider had been. You can see for the one at the bottom of that graph, which is time to last appointment when sick, the proportion of people who were seen the same or next day the last time they were sick. There's a huge gap between the best performer, which I believe is the Netherlands, at over 90%. We're seen within 2 days of requesting an appointment, and it's down under 40% for Canada. And that's the worst performance of those 8 countries. And we're still the worst performer in the more recent surveys as well. The next one looks at health information technology and office systems. And there's a whole bunch of detail here about use of EMRs, electronic test ordering, electronic prescribing, electronic drug alerts, computerized tracking of test results, computerized reminders to patients, computerized physician reminders, and so on. But you can see the huge gap between EMR use and functionality in Canada compared to the best performing countries. We ranked last or next to last on almost all of this. So despite having pretty good level of attachment to a primary care provider, our infrastructure lags behind other countries, and access to care clearly, timely access to care clearly lags behind very substantially. This one is about care management approaches. So use of non-physician staff to manage care, financial support or incentives for adding non-physician clinicians to the practice team, routinely providing patients who have chronic conditions with instructions for managing their care, and routinely giving patients written lists of medications. Again, big gap between Canadian and national performance. So these are data from the physician survey of 2009, and they're in comparison with 11 countries. That's the final set of data. And the final one I'm going to show here is on performance monitoring. So this is routinely receiving and reviewing data on clinical outcomes, receiving and reviewing data on patient satisfaction or experience, clinical performance being routinely compared with other practices, and having processes for identifying and following up on adverse events, and that those processes are working well. And same picture, big gaps. So in terms of, again, just reinforcing, infrastructure and access are 2 areas where Canada is way behind most comparator countries in these surveys. Again, just reminding you, though, I've shown you the worst, not the best. Canadian performance. So the next part of this talk is going to really look at, well, where do we need to go? And clearly, there's lots of room for disagreement about where we need to go. And I'm going to be pretty provocative about this, or at least pretty definite, recognizing that there's lots of room for disagreement. This is a very busy slide, and I suspect you can't really see it, but I think it's a really powerful illustration of how, at the practice level, the way in which care is delivered and experienced needs to be changed. And so if you don't mind, I'm going to kind of go through this. So on each, as you can see, there's two columns. One is kind of where we are yesterday's, and it's often today's care. The other one is tomorrow's care. And in some places in this country and some places in this province, I'm sure they're already providing tomorrow's care. So it's not as black and white as this shows. But it's, so in the reading from the left column first, our patients are those who make appointments to see us. And that's pretty traditional. When I was in practice, my patients, I dealt with what came at me, and that essentially constituted my patient population. On the other side, our patients are those who are in our panels. We have assumed responsibility. We have a rolled panel. Patients' chief complaints or reasons for visit determine care. And I can sure relate to that for most of the work I did as a primary care provider. On tomorrow's care, we systematically assess all our patients' health needs to plan care. Left-hand side, care is determined by today's problem and time available today. Right side, care is determined by a proactive plan to meet patients' needs without visits. Email, telephone, various forms of self-management support. Care varies by scheduled time and memory or skill of the doctor. Oh, too true. Care is standardized according to evidence-based guidelines. Again, we're moving, but we haven't got to tomorrow's care yet. Patients are responsible for coordinating their own care. And on the right side, a prepared team of professionals coordinates all patients' care. I think this is especially when you think of the points that Dan made yesterday, this is not presented in the way I would do it, but the point is patients are often on their own to figure out what they need and where to go. They can be supported and assisted in making decisions and accessing the appropriate care. I know I deliver high-quality care because I'm well-trained. We measure our quality and make rapid changes to improve. And we're starting. I mean, the quality improvement support work that's going on is really, some practices, in some cases many practices, are doing exactly that. Acute care is delivered in the next available appointment and walk-ins. Acute care is delivered by open access and non-visit contacts. It's up to the patient to tell us what happened to them. We track tests and consultations and follow up after ED in hospital. Clinic operations center on meeting the doctor's needs. A multidisciplinary team works at the top of our licenses to serve patients. So that gives you a flavor for some of what we can do and are starting to move towards. This is a slide that I've stolen from Daniel Duffy, Tulsa. I thought it's a nice summary about the kinds of changes at a clinical practice level that could really make a difference. This is an attempt to capture what the healthcare system might need to look like in the future. And here the person, their family, and informal supports are at the center of the system. The primary care team supports them, provides the majority of their care, and serves an integrator and coordinator function in relation to other health and social care sectors. These other healthcare sectors, specialist hospital service, long-term care, home and community services, public health, interact directly with patients, not all mediated through the primary care team. The primary care team can serve that integrating and coordinating role as needed to assist the patient in whatever journey they make through this system. And then they're drawing on both the patient and that primary care team, drawing on community resources and social services that respond to those patients and families at the center. Yeah, this is about the whole issue of, well, what do we want that health system to do, and why do we want to change clinical practice at the practice level? What are we trying to do? So this is a way of a grid that tries to integrate the IHI's triple aim, which I know is getting a lot of currency here in Saskatchewan, which aims at improving population health, patient experience, and reducing or controlling healthcare costs. But also maps those onto the Institute of Medicine's improvement aims that they articulated in their classic Crossing the Quality Chasm document. So their safety, effectiveness, person-centeredness, timeliness, equity, and efficiency. So, some thinking along these lines. This is just one way of looking at aims for improvement, but it can serve an orienting function when you're thinking about, well, what do we need to do? And how will we know whether we've got there? What are the key things we're trying to achieve? And then using a framework to identify the key measures that you want to track over time to monitor health system performance and identify areas where improvements are needed. So this next couple of slides addresses the issue of how will we get there. And this is a personal take on this, but it's not just out of thin air. It's based on looking at the literature and international experience and trying to think about what are the characteristics of high-performing health systems. What set of things do you need to put together to ensure outstanding primary healthcare system performance? And I emphasize that this is a set of features. It's not, well, we'll do one or we'll do that. I have a sense that there's a whole lot of necessary but not sufficient conditions, and if you act on one or two or three of them, you may make a little bit of progress, but there's probably a need to identify the sufficient conditions. And that's why I kind of present this as a bit of a package to think about what are all the things that really need to be in place if we're going to achieve those aims that we just saw, or we're going to create that kind of healthcare system that was on the earlier figure, and have clinical practices delivering that care of tomorrow. So here's a proposed set of some of those characteristics. First is a clearly articulated policy direction that is anchored in public values, needs, and preferences, but provides that orientation, recognizing that in almost every instance, change is only possible incrementally. It's hardly ever that the window of opportunity opens for the big transformation. But given that it's incremental, it really seems to me to be vital that you know where you're trying to head. So even if you know you can only get there in steps, you may be able to move in one area at one time, but not in another. But at least you've always got in mind where you want to, the direction of movement, a roadmap. Not necessarily a blueprint, but at least that guide for the road you need to travel. The second thing, and I think this is really critical, is to have in place primary healthcare governance mechanisms, especially at the community and regional level, but probably also at the provincial or territorial level. The primary healthcare system is incredibly fragmented. Little units, hundreds, thousands of them. And so in trying to get them to relate effectively to each other and to the rest of the system, it's just a mind-boggling task. I mean, how does a hospital engage primary care? One practice at a time? I mean, that can't happen. or community care? How do they relate to primary care? So it seems to me that we need to be thinking about establishing organizations that have governance function at the community and regional level for primary care before primary care can really be effectively integrated internally and with the rest of the system. And this problem has been recognized in some other jurisdictions, certainly the UK, New Zealand, and Australia have each taken different approaches to try to establish primary care governance. Quebec has regional family medical structures which are not particularly participatory. So how well they really do that integrating work. BC, as many of you are moving ahead with divisions of family practice, which are very physician-centric organizations, but do get infrastructure support, but also have an expectation that they'll negotiate responses to identified community health needs collectively with the regional health authorities. So there is an accountability arrangement, and it gives a voice to primary health care as well in dealing with other sectors. But for the most part, other provinces don't have anything like that. And it seems to me it's very hard to make system-wide progress, to scale things up to system level in primary care without a body that can take on some of the coordinating tasks, can support quality improvement locally, can hold each other accountable for quality of care. We all hear horrible anecdotes about some of the difficulties some people experience in relationships with the primary care provider and access. Classic problem that is finally being talked about is in response to being overwhelmed, there was a tendency that got quite widespread for family physicians to limit the number of problems they would deal with at a visit. So some physicians, and it was a desperation move, but a thoughtless desperation, was to say, well, you've only got one problem you can bring up today, and if you've got two, you'll have to make another. If you've got three, you'll have to make 2 more appointments. And people were doing this, and we talk about not being patient-centered. But, I mean, and now the professional associations are speaking out publicly and say this is not acceptable. But there's really never been a mechanism. I mean, physicians know that other physicians do some things that are pretty questionable. But there's no real mechanism for dealing with it. It can't be the Ministry of Health that deals with it, or even the Provincial College of Physicians and Surgeons can't deal with all of this kind of stuff. So a local body of primary healthcare peers, I think, could be given a responsibility and expected to deal with that kind of issue. I could go on a long time about this one because I think it's so important to system improvement, but I'll try and restrain myself. Patient enrollment, I've already talked about. Interprofessional teams. I think, although I've had discussions, I'm not sure how strong the body of evidence. I think there's a growing body of fairly persuasive evidence that on average, team-based approaches to primary care are more effective than traditional arrangements. It's a growing body of evidence, and it's not comprehensive in the sense that it covers all domains of primary health care. But I think that's one of the elements that needs to be there to achieve really high-performing healthcare systems. There's tremendous opportunities to take advantage of the skills and expertise of other than physicians to do some of the things that physicians are not all that great at and aren't trained to do. But there's challenges, and it's a real cultural adjustment, especially for physicians who, first of all, used to being the boss. But also, there's a loss. I mean, if you're there's a lot of pleasure in doing some of the more routine things, family practice, well baby visits, annual health exams, prenatal care. These are things that can be done well or better by other people, but there's a loss that you experience when and sharing that responsibility and have other people do some of those things that are fun, even if they aren't at the top of your training and skill. Funding and provider payment arrangements aligned with health system goals. I think it's partly how do you encourage people to do the right thing, but how do you avoid funding and payment arrangements that have perverse effects? It's almost avoiding doing wrong is more important than figuring out this magic bullet that's going to make everybody behave properly. I mean, the fundamental motivation for doing a good job is always going to be internal. And sometimes when you start to play around with external motivators, you get in the way of that really important desire to do good work that motivates most of us. So it's a tricky business. You can do a lot of bad things with payment and remuneration methods, and you can spend a lot of money for very little gain. There's lots of examples of that in the pay-for-performance experience, either having no impact or having some impact, but at a huge price. So, but it is important to be thoughtful about how you fund organizations, how you remunerate people, to ensure that you're encouraging the right things, not displacing important things by an overly focused attention to the things that are incentivized. Staying out of the way of people. They need to do. Leadership, this is a party needs to be said. We all recognize that leadership, particularly in the case of primary healthcare professional leadership, but also leadership from health authorities and ministries of health, governments is really vital. It doesn't happen without strong and effective leadership. So we need to think about how do you support and train leaders who are going to move things forward. I'm going to try and speed up a bit because I'm waxing on here. I am okay for time. Okay. So patient engagement, and that's kind of a general term for a lot of what Dan Fox talked about yesterday. It includes supporting patients in self-management, giving them direction over their own care, and making sure they have the information they need to make decisions that are consistent with their preferences and values, but also to engage them in the design or redesign of systems of care. And I'm thinking of this at a practice level, not just at the system level. And certainly, I'm aware of practices and primary care organizations that have really taken this on seriously. It's not so easy, but the easier thing to do is some kind of survey of patients. Probably, and that can be very helpful. As long as it gets out of the kind of how satisfied are you with care and really gets down into asking questions that are about meaningful aspects of the patient experience. But I'm aware of practices that have had patient focus groups. One practice in Timmins that had three focus groups with patients. One was with a group of patients who were basically young to middle-aged, healthy people whose requirements were for preventive and episodic care. Another focus group was people with a single chronic condition. I had a focus group of people with diabetes. And then the third was people with multiple chronic conditions. They had these. They asked them about their patient experience. What happened? What was good about it? They had them kind of talk their way through their patient journey. And the learnings that they drew from that were incredible. They prepared a report on this, and they had a lot of surprises. This was a very high-functioning family health team in Ontario, really committed group of people. They thought they were doing everything right, and they weren't doing it from that patient perspective. And they made substantial changes very quickly in the way they organized their in response to the really insightful and surprising in some cases, feedback they got from the patients. So that's another way in which they can be engaged, not just in their own care, but in helping to shape the delivery of services in the practice and more broadly. Health information technology, and I think it's the keys things here are making sure it has the functions that patients and providers need to make decisions and deliver the best possible care. So often our EMR systems that we're using now don't have the kind of functionality that allows you to really understand patients' journey over time, to be able to identify when they're missing follow-up that's needed, where their condition is not under optimal control, when they're not receiving preventive care that they need to be offered. Not always decide they want it, but at least to be offered. And to support things like patient access to the record electronically, ability to interact with providers electronically, and as well as in person and by telephone. I've talked a fair bit about quality improvement. The key thing here is you can't do quality improvement without appropriate performance measurement. You need to be able to measure performance in order to identify where the need for improvement is greatest, and to know whether the changes you're making to try and improve performance are effective. So there's that. Performance measurement is just a kind of a fundamental requirement if you're going to do any serious quality improvement. Coordination, integration, partnerships with other health and social services, something that, given our really very strict siloing in our system, we don't have vertical integration to any extent at all, is a huge challenge and has to be addressed through a variety of mechanisms. I'm not going to spend a lot of time kind of talking about what some of those might be, but it's certainly an area that needs to be systematically addressed. And then evaluation of innovation, and again, we're evaluating public goods. We ought to be sharing the results of those innovations so that not only can the people in the ministry learn from them, or not learn, I mean, they go to the shelf, but really be systematic about start them early enough so that you're actually able to get baseline measurements, resource them adequately, and make sure the results get widely disseminated. And then a kind of the attention to the need to support research to inform policy and practice. If we want to have a continuously improving system, it needs to be informed by a continually evolving body of evidence. So there's my short list of what we need to do. I'm going to really quickly go through the last two slides. How much time have I got, Greg? Okay. I think I have 3 or 4 more slides. So I will really just put this list up for you to contemplate. There are challenges. Because we take an incremental approach, we do pluralism of this and that and the other thing, we got a complex system. And so there's energy gets consumed in the management and implementation of that complexity. Physician engagement is a continuing challenge. The transition from physician-centric to team practice to teamwork is a challenge for everybody and needs to be supported. It won't happen spontaneously. It is a difficult transition, and people need to be given coaching and tools to do that. Investment requirements. You gotta invest in change. Or just wagging your finger at people and saying you got to do better doesn't produce change. And so the 90s was in part such a disaster for primary health care innovation because nobody had money to invest in innovation. And the hope was, naively, among some people, others were more realistic, if we just turn off the tap, people get really creative and they'll be efficient. And so they'll be able to do more with the same or less. And of course it didn't happen. People just cut back, hunkered down and survived the period. But it meant that there was no investment in the infrastructure, the policy development, the funding that are needed for effective change. And that continues to be, I mean, with the recent recession and the resulting deficits, that's going to be a challenge in this coming period. We had it better during the first decade of the 2000s. Money was a little freer. It's very tough to have substantial change without investing in change. Equity, we don't pay enough attention to it. We don't measure it very well at the practice level, at the system level. And we know there's not equitable use of services, and there's certainly not equitable health status. But we don't have a way of even tracking how well we're doing or whether the kinds of things we try to do, which tend to be relatively few, to address health inequities are really being effective. And the challenge of evidence-informed decision-making. One of the huge challenges in primary health care is medical and social complexity. Clinical practice guidelines are designed for managing a specific disease. It doesn't work just to add all the disease-specific guidelines together when you're managing people. There are a lot of people concerned about this, a lot of work being done on it, but it is really a tough one to crack, but it's exactly what primary health care providers are increasingly dealing with. This is a quick run over what I think are the lessons learned from both the pre-2000 and the post-2000 periods, or the lessons we should have learned, whether we did or not. So I think one of them is that the policy legacies and entrenched professional and public values limit the possibilities for radical reform. Big bang reform is not going to happen. You use sitting back in on your vacation and thinking, okay, I'm going to redesign the healthcare system. It's hard to get there from here. And I think that's been largely recognized since in the post-2000 period. And so almost everywhere in the country, policymakers are recognizing there's clear recognition that there isn't any single right model for funding, organizing, and delivering primary health care. Population serves, it depends on historical and social context and so on. So that, again, part of what happened pre-2000 was this pursuit of the perfect model, become universal in everything. Changing physician payment methods and organizational forms doesn't automatically lead to changes in the delivery and outcomes of care. So a lot of change capital was spent in Ontario, for example, on changing payment methods. An important thing to do, but there was a naive expectation that somehow that would itself result in substantial changes in the way care was delivered. That wasn't a reasonable expectation. You have to do other things to take that next step. Primary healthcare renewal requires major investments in system transformation and infrastructure. We learned the lesson that it will be forgotten potentially during this period of fiscal crisis. Broad-based primary healthcare transformation is possible only with the support of organized medicine. A lot of people wish it wasn't so, but I think the experience tells us that you can't go around them. You've got to work with them and make some compromises in order to progress. System level, this is the positive one. System level change is achievable through a voluntary process, is incremental, cumulative, and allows for multiple complementary and continually evolving organizational funding and payment policies. I don't know whether there's evidence for that or it's just a belief I have. Or a hope, I don't know. This is getting to the end here. So I think the challenge is to stay the course. We've started a process of primary healthcare transformation, but it's really incomplete. Nobody's done it everywhere. Everybody's done a lot of things, and many of the innovations have been very exciting and are certainly moving the right way. So it's scary that we're now in a tight fiscal period where the investments in change may dry up. What might help for that not to happen is if there's we, and I include myself in this, can build a strong coalition of support for primary health care improvement among professionals, and so it's the nurses and the doctors and the OTs and the physios and the community care providers and so on, speaking together to kind of highlight how fundamentally important it is to build a strong primary healthcare foundation and engaging civil society. Primary healthcare sector, we were having a talk earlier at the Ministry of Health. Even the term primary healthcare doesn't really resonate with very many people, even at often with governments or with the public. So there's a building job to be done if we're going to continue to make progress and avoid slipping back because of the fiscal problem. Try and end it on a lighter note here. I suspect that as primary healthcare providers, as managers, policymakers, and citizens, we sometimes feel a bit like Edward Bear as we contemplate the present and future of primary healthcare. So here is Edward Bear coming downstairs now. Bump, bump, bump. On the back of his head behind Christopher Robin. It is, as far as he knows, the only way of coming downstairs, but sometimes he feels that there really is another way, if only he could stop bumping for a moment and think of it. And isn't it that where we sometimes are? We know that things aren't right, but we don't know what the hell to do to change them. Now, I'm going to try and end on a positive note, because there's a great quote from William Gibson, who's actually a fantasy writer, that he said, the future is already here. It's just very unevenly distributed. And this is so true. You look around this province or this country, a lot of the things that I'm saying, this is what we need to do, are already being done. Piecemeal, sometimes in little pockets. But the future is already out there. We just have to scale it up somehow across the system. So thank you.